Welcome to Neuroimaging 101. What this is? Fundamentals of Neuroimaging, a series that I prepared for the pathologist. Where do we start? Basic T1 and T2 sequences, being able to tell the difference between whether you're looking at a T1 or a T2. It's pretty simple. How long does it take to master the basics? Well, about 5 minutes. Let's go. The four workhorse sequences in neuroradiology are T1 without contrast, T1 with contrast, T2, and T2 flare. There are two simple principles which will allow you to tell the difference between a T1 and a T2. First principle, on T2 weighted images, water, H2O, is hyperintense, bright, white. That's as basic as it gets. All you have to remember is T2, H2O. Water is bright on T2 weighted sequences. Second principle, for this one, let's compare white matter with gray matter. White matter is white because it's rich in myelin. Myelin is a lipid bilayer, cell membrane. It's rich in fat. So essentially, white matter is mostly fat. Therefore, normal white matter has less water, being fat, than gray matter. Therefore, white matter will be darker or hypointense compared to gray matter on T2 weighted images. And therefore, white matter will be brighter or hyperintense compared to gray matter on T1 weighted images, because T1 and T2 are essentially opposites with respect to water content. All right, so T2, gray matter, hyperintense, bright, white. T1, white matter, hyperintense, bright, white. All right, let's look at representative T2 weighted images. And you can see a coronal T2, the top panel, lower panels, and axial T2 above the level of the lateral ventricles. All right, CSF, cerebrospinal fluid on a T2 will be the brightest thing that you see. Bright, white, hyperintense. Gray matter, because it has more water than white matter, will be hyperintense to the subjacent white matter. So for example, if you look at the bottom panel here, you see the brightest thing that you're seeing in the subarachnoid space, or above the level of the ventricles, is the CSF. Then when you compare the gray cortical ribbon with the subjacent white matter, the cortical ribbon is brighter, hyperintense to the underlying white matter. This has to be a T2 sequence. All right, so if the CSF is bright in the ventricles or in the subarachnoid space, it's a T2 weighted sequence or one of the T2 weighted sequence flavors, such as gradient echo, etc. All right, T1 weighted images. On a T1, it's going to be the opposite of a T2, essentially. The CSF will be dark, black, hypointense, but that's not always going to be reliable. So what we're going to rely on is the gray matter. The gray matter in a T1 weighted image will be darker or hypointense compared to white matter on T1 weighted images. So the white matter is brighter than the gray matter and much brighter than the CSF on a T1 weighted image. All right, so is it a T1 or a T2? Here's what you do. Go to an area away from the lesion, because you don't want to be misled by vasogenic edema and all these other pathologic processes. Get away from the lesion to an area of normal brain and compare the cortical gray ribbon with the immediately subjacent white matter. If the cortex is brighter than the white matter, it's a T2 sequence. If the white matter is brighter than the overlying cortical gray ribbon, it's a T1 sequence. It's that easy. Okay, you ready to try it? Here's two panels, left panel, right panel. What do you think? Which one's T1, which one's T2? Stop looking at the lesion. Don't look at the lesion. Look at the uninvolved, quote, normal white matter and gray matter, normal cortex. Panel on the left, the white matter is clearly hyperintense to the overlying cortical ribbon. All right, that therefore has to be a T1. Panel on the right, the cortical ribbon is hyperintense to the underlying white matter. That will be the T2. Simple. Note, whether or not a lesion exhibits contrast enhancement is assessed only on T1 weighted sequences. So what you call a lesion that's very bright on a T2 weighted sequence, you don't say contrast enhancing. You can't assess it on a T2. What you would say is a T2 hyperintense lesion. All right. Always, this is another caveat, always compare the T1 without contrast with the T1 after contrast when you're trying to assess the presence of contrast enhancement. The reason is there are many substances, both normal and abnormal, that are intrinsically hyperintense on T1 weighted sequences without gadolinium, and you need to know that. So good practice would be to always look at the T1 pre along with the T1 post when you're assessing contrast enhancement. All right, so let's look at that. Here we have a great example, a T1 without contrast. You see that the white matter is hyperintense to the overlying cortical ribbon, and there's a lesion that is hypointense to the white matter, pretty much isointense to the gray matter. We give gadolinium or gadolinium chelate on the T1 post. You can see the lesion lights up, homogeneous, avid contrast enhancement. This is actually a meningioma. That's contrast enhancement. And then just for purposes of comparison, here's the T2. It also has some water content. Fine. All right. Do not confuse T2 brightness, hyperintensity, which is water, CSF, or vasogenic edema, with contrast enhancement. All right, look at this T1. There's a lesion. You know it's a T1. How do you know it's a T1? Did I mess it up? The white matter is hyperintense to the overlying cortical ribbon. So yes, it's a T1. All right, question for you on this middle panel. Is the lesion contrast enhancing? What's your answer? Is this an enhancing lesion? It's certainly bright, white, hyperintense. The CSF in the subarachnoid space is bright. It's the brightest thing that you see. All right, look up here. Everyone see the CSF? All right, it's bright, okay? And the cortex, the cortical ribbon, is brighter than the white matter. Therefore, this is a T2 sequence. Therefore, you cannot assess contrast enhancement. You can't say it's enhancing. You can't say it's not enhancing. What you can say is it is a T2 hyperintense lesion. Turns out it's not enhancing. This is the T1 with contrast. You see a little bit of either vessels or residual white matter, probably not enhancing lesion. All right, whether or not a T1 pre versus T1 post, how do you tell the difference? You can look for the bright blood vessels, choroid plexus, or the nasal epithelium, which will light up with contrast with contrast administration. So here's just an example: T1 pre on the left, T1 post on the right, and you can see the blood vessels lighting up, pre versus post. This is usually pretty easy. Okay, last sequence. What is a T2 flare? Fluid attenuation inversion recovery. Think of it this way. T2 flare suppresses the normal white water signal, leaving only the abnormal water signal. So normal water, cerebrospinal fluid in the ventricles, in the subarachnoid space will be suppressed, taken out of the equation, leaving only the abnormal water, which would be vasogenic edema. It could be diffuse glioma. It could just be vasogenic edema around a metastasis, etc. All right, so I summarized it. Normal water, CSF, is suppressed. The ventricles and subarachnoid space are dark, black, hypointense, all right? However, so you might think, well, this must be a T1. However, the gray matter is still brighter compared to the underlying white matter, so it is absolutely a T2-based sequence, not a T1. And because the CSF was dark, it has to be a T2 flare. All right, you ready for a test? Let's have a little quick examination. The ventricles are going to be black on the image I'm about to show you. Is it a T1 or a T2 flare? Ready for the test? Let's go. T1 or T2 flare? Give you a couple seconds to think about it. Is it a trap? Yeah, of course it's a trap. I live for the traps. Compare cortex with white matter to determine if the scan is a T1 or T2 weighted sequence, period. Look at the panel on the left. The cortical ribbon is hyperintense to the underlying white matter. That's a T2. Look at the panel on the right. The white matter is hyperintense to the overlying cortical ribbon. That's a T1. Because the CSF is dark on the panel on the left, this is not just a T2, it's the T2 flare. All right, got it? Yeah, was that tricky? Was that unfair? Well, as I often say, nature's unfair. Cancer is unfair. The battle will never be fair to you, and the battle will never be over. You're going to have to stay on your toes. Only the dead know the end of war. Plato. All right, there's the T1 thrown in, just pure T1, just for comparison. And again, if you look at the area I've circled in yellow, white matter, hyperintense to the overlying cortical ribbon, that's the T1 in this thing. This was an intraventricular arachnoid. Let's go back just a second. This was an intraventricular arachnoid cyst. Did you know that arachnoid cysts can occur in the ventricle? Absolutely. Well, we'll just throw in a little bit of pathology then. Okay, next test. You see abnormal bright signal. There's going to be a lesion with bright signal. Is it contrast enhancement on a T1 post, or is it edema on a T2 or a T2 flare? All right, you ready for the examination? There you go. The question I would simply ask you, this is the way I usually ask it when I'm doing this in a small group or at a conference. I would simply ask, is this a contrast enhancing lesion? Yes or no. Now, I know I'm not showing you a T1 pre, so you could argue maybe it's something intrinsically hyperintense, hemorrhage, etc. But let's just accept that there was no brightness on the T1. All right, bottom line is the cortex is hyperintense to the underlying white matter, so it's a T2 sequence. The CSF is dark, so it's a T2 flare. It's a T2 flare, therefore, the bright signals you're seeing is edema. It's not contrast enhancement. You cannot assess contrast enhancement, but you can say that this is a T2 hyperintense lesion. You got that? Wasn't that fun? Okay, just a few practical notes. The superior sensitivity of T2 and T2 flare compared to a T1 post. All right, now here's the way I usually work this when I'm with a group that I can talk back and forth to. And I work the exam this way. What I say is, I'm going to show you an image, just one image, one cut in the next slide. There will be a lesion, and all I want to know is, where is the lesion? You don't even have to give me the anatomy, just point to it on the screen. It's that simple. I don't want to know if it's T1, T2, whatever, just point to the lesion. But here's the catch, and you point to the lesion as quick as you can. Here's the catch. I'm only going to show you one of the four basic sequences, the workhorse sequences. T1 without contrast, T1 with contrast, T2 or T2 flare, but it's your choice. You can see any one of those that you want. It's your choice. Well, look, here's the bottom line. 3 out of 4 residents, fellows, etc. say, okay, I'll take a T1 with contrast. There's a T1 with contrast. Do you see the lesion? That's that fast? Okay, how about a T2 flare? Yes, that was the lesson. The lesson is, for a non-enhancing lesion, like a lower grade diffuse glioma, as in this case, the T2 flare is going to be far more sensitive than the T1. Now, it's true, if you look at the T1 post, you can see the area corresponding to the lesion right here that is hypo-intense compared to the surrounding brain. But to use a wonderful neuroradiology descriptor, the conspicuity, degree of conspicuousness of the lesion on the T1 post-contrast doesn't come close to the conspicuity of the lesion with the T2 flare, the sensitivity, a really cool sequence. All right, let's take just another quick practical lesson. The advantage in many, not all, but many situations of the T2 flare over the T2. Where's the lesion? You see the lesion? Is it obvious? Is it obvious now? Yes, when we suppress the normal water, CSF, in the ventricles and the subarachnoid space, it can make smaller lesions adjacent or in the ventricle or adjacent to or in the subarachnoid space much more conspicuous. It can increase its conspicuity, which allows us to detect the lesion. All right? Many times, I'll just throw this in as a little caveat, oftentimes a T2 can actually be superior to T2 flare in the spinal cord for imaging, and perhaps in our integrative diagnostic medicine case conference that I run every Friday, we will talk about that in the future conference. And in this series of Neuroimaging 101 for the pathologist, I'll cover that at one point. So here's the bottom line. You're pressed for time. There's 8 neuro cases on the OR schedule. You're running behind for whatever reason. You need to look at all the images fast to get a handle on the cases. For a quick look, I always bring up the axial T2 flare, axial T1 post-contrast. If there is a post-contrast, put those side by side, compare them. And the T2 flare will be super sensitive. It will show you the full outline of the lesion, including any reactive vasogenic edema, diffuse glioma, etc. And the T1 post will tell you whether or not it enhances. Again, the caveat: it's always good practice to look at the T1 pre. Guess what? Done and done with this first lesson. Basic neuroimaging for the pathologist. You start with being able to recognize the difference between a T1 sequence and a T2 sequence. It's not rocket science. You can do it. All right, thank you. Much appreciated. That's the end of lesson number 1. I'll be posting further updates down the road. Thank you for watching.